as we noted, dialysis patients may have no symptoms of, may initially not suspect that they have peripheral arterial disease. A lot of them are not walking very much. They may have cramping in the legs or neuropathy. Oh, that's another point that I should make. Another reason to quickly be evaluated for any ulcerations is because there's several different causes for ulcers. It can be an arterial insufficiency problem, as we mentioned, or it could be a venous problem. And venous ulcers also needed to be treated aggressively, but they have a completely different treatment for them. They may require different salves and compression and what's called Unabut therapy. So they really need to be evaluated for that. The last thing is that these patients who were in this category of diabetes and renal failure may develop what's called a neuropathy. They may not be able to feel their feet, feel their toes. They have a nerve problem, which may result in them falling or not being able to walk properly, balancing issues. But also they may be damaging their legs. They're pounding their legs and not even realizing that they're damaging their bones and their tissues. So any patient who has an ulceration and has chronic kidney disease obviously needs to be followed. But I'm talking to the patients who don't have any symptoms. Patients who have chronic kidney disease and have no symptoms should definitely be screened for peripheral arterial disease. We want to catch this early to prevent the late stages of this disease. And again, as we said, the patients with chronic kidney disease frequently do not present with early stages of disease, like claudication or early symptoms, but really I've had patients who were completely fine one day and then developed a tiny wound, and within a week, they developed full gangrene, a black toe. So it really needs to be identified. Even if you don't have any symptoms, you should be screened to see if you have it, and it should be followed over time to see if anything progresses.